Hello, I'm Alicia. I am the Practice Nurse Mentor. This video is going to be about the upcoming changes to the chronic disease management framework that we do in general practice. This is specifically for Australian audiences only. This is not for anybody who is a nurse doing primary healthcare overseas. So we have much anticipated changes coming into effect as of the 1st of July 2025. So I thought that I would go through those changes just briefly, but focus this video a little bit more on some strategies to help adapt your practice to these changes, because there's a little bit of an anxiety about it. A little bit of uncertainty, certainly amongst the nursing population in general practice, a bit of worry and concern about what this might mean, and you'll know what I'm talking about as we get through the video. So thank you for joining me. If you're new to general practice and new to care planning, some of this might be a little bit difficult to pick up if you aren't already doing them. But if you're well seasoned in doing care plans, then you'll know what I'm talking about. I'm not going to go into too much detail on that front. This is specifically going to be discussing the changes that are coming up. All right, so first of all, I think I would just summarize what has changed and what hasn't changed, or what will be changing. So the main things that are going to be changing is, first of all, terminology. So what we've been dealing with so far is things called care plans, GP management plans, team care arrangements, EPCs, so enhanced primary care referrals. All of that terminology is pretty much gone or going. The care plans now will be known as chronic condition management plans. So the abbreviation you might see is GP, CCMP, or just short CCMP. This is going to reflect, I guess, the more streamlined framework that they're aiming for. So that's going to be the new names that we'll be more familiar with as of the 1st of July. The other things that are big in terms of changes are going to be the item numbers, so the Medicare item numbers. So previously we had 721, 723, and then we had the review item numbers, which were 732, which you could use for both a review of a care plan and the review of a team care arrangement. Those numbers are going. We're now going to have the plan is going to be 965. There are associated video health item numbers, which you'll see those when they come out. And then the review item number is 967. They are just the only two numbers that are going to be used now throughout the chronic condition management framework. The rebate amount for these has also changed. So previously for doing care plans, we had, for the 721, we could claim about $164 and some change. For 723s, it was about $130 and some change. And then for each review that we did, we could claim $82 and some cents as well. So doing all of those things, that was, the care plan and a TCA at the same time, it was nearly $300 for that. So there is now just a one fee for all of those, for doing a plan or for doing a review of that plan, and that is going to be $156.55. So this is where some of the anxiety is coming from. That is a reasonable amount of discrepancy in the amount of money that is going to be paid to practices for doing the care plans or for doing the chronic management plans. So moving forward, there'll be no TCA required, so you won't need to do a separate document, another duplication of the care plan, just to be able to provide referrals for the allied health. So therefore, there's going to be no multidisciplinary care requirements to meet, and there's also no minimum of 2 collaborating providers. So this is going to streamline the chronic disease or chronic condition management for people. So I think this is a good thing, because there was a lot of duplication and there was a lot of hoops to jump through in order to be able to claim the funding. So I think this is going to streamline things a hell of a lot more. The method of referral has also changed. So before, when you had someone with a team care arrangement, we could then provide what was called an EPC, which was essentially allied health referrals. So sending someone to physios, osteopath, chiropractor, podiatry, dietitian, all of those allied health providers. So now that system will change. We won't have to do a separate referral form from the 1st of July onwards. It will simply be a referral the same way that you would provide other medical referrals. Excuse me. So if your doctor is used to sending referrals through to see a specialist, it will be essentially the same format. You may want to customize something that's a little bit more unique to the allied health provider, something along the lines of, why you're referring them to the allied health provider and how many visits, so that they know roughly what to expect in terms of how many times the patient's going to come. The things that haven't changed is the eligibility to be on a care plan or a chronic disease management plan. I still have to get my head around that, saying the terminology. So excuse me if I say the wrong terminology here. But the eligibility hasn't changed. Anyone with a chronic condition or with a condition that is likely to be chronic or terminal is eligible to be on a chronic condition management plan. That is regardless of whether they seek allied health, that is regardless of whether they have multidisciplinary care, so a specialist or anything like that. So I think this is going to open up some avenues for eligibility. But there's always been that eligibility in terms of anyone with a chronic condition, but unfortunately they did have to meet certain requirements in order to be able to have the care plan. So the very basics of being eligible in terms of having a chronic condition, that hasn't changed. The frequency of the reviews hasn't changed either. I think previously the reviews probably weren't being done as much, and that's part of the background on why they've made the decision to change the rebate amounts, and I think they want to encourage more frequent reviews. So traditionally someone would come and have the care plan done, then they may come back once or twice throughout that 12-month period to have a review, and often it would be to perhaps change their referrals or to check in on some of the investigations or monitoring that they may require. But there's generally speaking a bit of a disparity between how many people claimed the previous care plan to how many times a review was actually performed. So they've always been eligible to be able to claim every 90 days, every 3 months. So that hasn't changed. I think we just need to look at how we utilize that a little bit more in the future. The number of allied health visits hasn't changed. It's still going to be the 5 per calendar year. The nurse item number is also remaining at 5. However, in the fine print, this does say that it's claimable up until the 30th of June 2027. So the next 2 years, I'm not sure whether we get more information about this, but it's quite possible that the nurse item number, the 10997, will be discontinued unless they decide to replace it with something else. But there is no information about that right now. But for the next 2 years, while we have this transition period, the nurse item number is still claimable for 5 times per year. So just be mindful of that, making sure that you're claiming them as much as you can. Other points to mention as well, the My Medicare registration, that is still something that they're encouraging us to do at this point. If someone has already registered with My Medicare and nominated their primary care provider, their GP, then that GP is the only one who's going to be able to do the chronic condition management plan for that patient. If they haven't registered for My Medicare, then their usual doctor can just do it. But I think there will be a push over the next year or two to really get those My Medicare registrations done. Also, in that at the end of this 2 years point, anyone who needs that home medication review, the DMMRs, from the 1st of July 2027, that will only be accessible for people on a chronic condition management plan. So this will come, I'm going to talk about this a little bit more in strategies in a moment, but remember that anyone who potentially is going to need a medication review through the pharmacy, they're going to need to be on a plan. All right, so how are we going to adapt some of these changes into our practice? I think the main thing that people are worried about is how they're going to mitigate some of that financial loss in terms of that reduction in the rebate amount for doing the plan and the reviews. Different practices will develop their own strategies based on their demographics and their business model. So if they're a private billing practice, I'm certainly hearing that they're going to intend to charge a private fee, and the patient will get the rebate back of that $156.55. So they'll be out of pocket a small amount. That's not going to work for every practice, and especially when we're looking at people with chronic conditions, they tend to be in an older age demographic and pensioners. That's potentially not going to be a viable option for some practices. So I guess it comes down to strategizing with your team. I know in my workplace, we literally just had a meeting about it yesterday, and I'm doing mentoring tomorrow night with a group of other nurses as well, from different practices all over Australia. So I'm keen to hear how that's going down through some of their workplaces. I think it's a really good opportunity also to reflect upon our response to change. Typically, we often don't like change, and there is that bit of a knee-jerk reaction to change and going, oh, this is going to be bad, this is going to be negative. But I think having an open mind, trying to having a positive attitude about it. It's good for lots of different reasons about, just fostering that job satisfaction rather than going, oh God, this is going to be horrible. Everybody's going to work all stressed and anxious, and it doesn't create a really good workspace. That can then affect your patient care and our own mental health as well when we're thinking about that job stability and am I going to lose my hours or something like that because the care plans, there's going to be all these changes. I think there's always that bit of a flurry whenever big changes are announced, and being calm, sit there and look at the money, look at the data, look at your demographics, look at your business model, and then start to really come up with some strategies. And so tonight I'm just going to put forward a couple of ideas that I've come up with, and certainly that I've sort of been talking with other people about strategy. So hopefully this can help if you can take this back to your workplace. So the number one thing I think is going to be the frequency of reviews. You're really going to need to capitalize on doing those reviews every 3 to 6 months. If you've only been doing reviews once a year or none a year, then you're really going to start to have to think about forward planning with your patients to get them coming another once or twice throughout the year. Now, you can schedule these ahead of time. When you're sitting there and you're preparing the plan, it's go, okay, Mrs. Jones, let's get you back in 3 to 4 months or whatever you think is appropriate with that particular patient and their needs. And we're going to continue what we've started here today with the plan. And we can review some things. We can, get your bloods done and, doctor can check those. Then we can update your referrals, get some feedback on your EPC. I'm going to say that again. Get some referrals on some feedback on your allied health visits. Is there anything else that we need to be doing for you and sorting out with regards to your chronic condition management? we can bill the 967, the review, and instead of, say, if they were coming in for a standard appointment with the GP and just being charged a 23 or a 36. So that 967 is going to be more financially viable to bill that rather than the other smaller amounts. So utilize that GP time, even if it is just with the GP and not with the nurse. But the nurse can certainly see the patient first, do some OBS, do some other bits and pieces. Are they up to date with their screening and their immunisations and such? And then the GP can finalise the rest of the visit and bill that review. So I think that has the capacity to work really well. I think it's also an opportunity for that patient to take advantage of a bulk billed appointment if that's the model that you're working with. Time and discussions are limited to just that stuff with regards to their chronic disease and not so much with some other things, anything new. So you're going to need to be pretty straight down the line with what the expectation is for those appointments. But I think it's a good opportunity to, pepper in some free appointments for the patients throughout the year, especially at the moment when, they're looking for some financial relief. Can we get more patients on a plan? So remember, the eligibility is simply just anyone with a chronic condition. They don't necessarily have to be seeing specialists. They don't necessarily have to be accessing any allied health. Most certainly that can be introduced down the line, but once they're on a plan, then it's just a simple question of adapting and reviewing and updating things. So I think thinking about the plans as more of a dynamic evolving living document rather than just this one and done and then I'll see you next year when we do it all over again. Prioritizing those the tasks that you need to do at each session and planning it out ahead of time, making a note in your session this time, so okay, at the next visit these are the things that we want to address. So I think having a bit of a look at your patient cohort, people with chronic conditions, if they're not on a plan, get them on a plan. Anyone with a chronic condition, and also anyone with polypharmacy. Remember, we're going to be needing to have them on a plan if we're going to potentially do home medication reviews down the track, especially if their needs are changing. It's a good opportunity to get them started on a plan now, ready for the future. As I said, they don't have to be accessing anything else at this point, just simply get them on the plan. And even if you're just doing one review, maybe two during the year, then again, you can be utilizing that review item number. Can your practice be doing any video consultations if that's something that you're not already doing? Is there an avenue to add this in as a different service because you want to cut down a little bit on your nurse face-to-face time? I'm going to talk a bit more in a moment about the importance of nurses still in the role that they play with chronic condition management. But yeah, some practices don't really utilize the video consultation aspect to things, so that might be something that can work. Nurses can work from home if they've got computer access to the software, and they can certainly be doing the video calls, and then the GP follows up with them at some later time, and the care plan stuff is half done. So there's lots of different ways that it can work. So utilizing the video item number might just help be a little bit more time efficient for some practices and some models that they've got there with their staffing. Because that cost efficiency, I think, is going to be the thing that really need to strategize about. I think a big aspect is going to be simplifying the care planning process at your practice. I love that there's so many nurses out there, and I'm one of them, to be honest, that is, very holistic in their care, in their chronic disease management with their patients. They like to really be very thorough and cover all of these different things, and it, can take 30 to 45 minutes to be helping prepare a care plan. Moving forward, that time frame is probably not going to be efficient or cost effective overall. So looking at ways to condense what you're covering in that time. As I said before, prioritizing what needs to be done right here, right now in this plan, and then schedule the review in 3 months' time and follow on. Do the next part, and just have that evolution of the plan as it's just continuing to be reviewed and expanded upon. It doesn't all have to be done right here, right now in this one session. So I think that's going to be probably one of the biggest changes and adaptations that practices and nurses are going to have to do. Utilize the health assessments a little bit more, especially if the people in those eligible claiming groups, 45 to 49-year-olds, 45 to 50-year-olds, the over 75s, heart health checks, those kinds of things. So if they're eligible to in any of those groups for having a health assessment, get them booked in for that and do some of that more holistic healthcare, and leave the chronic disease to the chronic disease plans and sort of try to break up the bits and pieces a bit more. You're still covering everything. You're still providing top-notch holistic healthcare to your patients, but we're, picking where the best avenue is to address them in terms of time and the Medicare claiming. So I think some of these might turn into some great quality improvement projects for your practice as well, and you're still going to be generating some nurse time and some billings for those sorts of things. So then, as I was saying before, the nurses are still a very valuable part of the care planning process. They still can do a whole lot of work in that preparation phase and helping to do the groundwork for the GP before the patient then goes and has their session with the GP to finalise the plan and organise any arrangements that need to be done in terms of investigations or referrals. Having the patient coming in and spending that bit of time with the nurse first. The GP can be seeing the other patient while this is happening, and then you're just kind of continuing to move through this cycle the same way that you're probably already doing it now. I know there's been some conversation around, the GPs are just going to get rid of the nurses and start doing the care plans all by themselves. I don't think that will last. I think if that's what they want to try, then I think they'll realise how useful the nurses are in helping to do some of that stuff, and they might find it a little bit less time efficient. I think they'll find that they're seeing less patients, and then they'll get the nurses back in to do that prep work again and keep on rolling the same way that they've always done it. So I know that there are doctors out there who do their own care plans. I'm absolutely not saying anything bad about that. I think that's fabulous that they do it, but it's amazing how much impact the nurses have in doing a lot of this chronic disease management stuff. And I think the majority of doctors who have the nurse helping them are very appreciative of the input that we have. I think the patients also appreciate it as well. They love that they've got that team of people at the doctor's surgery that helps to look after them. So I think it's really important. I think nurses still remain having a very important role to play in the whole chronic condition framework. So yeah, because I know that this is all starting to be quite streamlined and that we don't have to quite do so much paperwork, but it's still a process. There's still a bit of work to do, and nurse assistance is going to be very valuable in that process. So it remains to be seen, I think, how much of a knee-jerk reaction there is with the whole nurses and cutting their hours. I think if it does happen in some practices, potentially it will come back up down the line when they realise that, okay, we can actually get this more efficient if we have some help, and I think the nurses will come back again. So I think they were the main things that I really wanted to cover with this video, with some ideas, and I'm sure there's going to be plenty of other ideas thrown out there. Feel free to pop them in the comments if there's some things at your workplace that you're going to be doing. But I think just a couple of points with regards to people who are on care plans, who are not currently on any care plans, and they have got a chronic condition. It's very simple. In the past, you probably haven't bothered. So a couple of examples I can sort of think of the top of my head: someone who has osteoporosis, they're on Prolia, or maybe they're on an annual infusion or something like that, but they don't really have any other chronic conditions. They don't see a specialist for this. They don't have any need to go and see anybody else in terms of management of their osteoporosis. So in the past, we probably wouldn't have bothered to put this person onto a care plan. But moving forward, there is absolutely no reason why we shouldn't. So we still have to monitor their calcium and vitamin D. We need to do their serology. We need to be making sure their bone density is done. We need to be doing height and weight checks still. We need to be doing fracture risks and nutrition assessments. Do they need to be having education about physical activity? Could they do with having a referral to an exercise physiologist and get into a healthy bones program, all that kind of stuff? If they have had the history of a minimal trauma fracture and that's how they got diagnosed with osteoporosis, then most definitely there's room for them to be given referrals to group sessions for exercise physiology or something like that. So this is exactly the kind of person that could benefit from being on a plan if they've never been on a plan before. Same with obesity, weight management. Someone's about to be commenced on some medication to help them. So whether that's phentermine or semaglutides or anything like that, they're about to start some kind of medication to help with their weight management. That's obviously going to require monitoring and tracking of their results. It's going to require patient education about physical activity and some diet. You're going to probably help them, with self-administration of their medication if they're doing the injectables. Discussions about that whole mindset, the process of change, and optimizing their success with things. Side effect monitoring and management if they experience any of that. And of course, clinical review of the medication. Is it being effective? How are they titrating their doses, and is it working? There's avenue for these people to be brought back in 3 months' time to have a review once you get them onto a plan. And then of course there's, referrals for dietitian, exercise physiology, psychology, all of those kinds of things. So again, another one where don't often see people on chronic disease management plans if it's just for weight management. If they were having diabetes or heart problems or something like that, then absolutely they would be. But then this is also another person who might be eligible for something like a heart health check. Or a diabetes assessment and doing a diabetes health risk assessment if they're aged between 40 and 49. So looking a little bit more outside the box to looking at how you're optimizing your patient care and how you're optimizing your billings so that you're buffering some of that financial losses from the change in the rebate with the care plans. So I think I'll leave it there in terms of the kinds of things that we might look into doing to help strategize with these changes that are coming up. All in all, I feel positive about it. I think that it's going to be more streamlined. I think it's going to work a little bit more efficiently in terms of our time. And once we kind of, get through some nuts and bolts with how we're going to adapt to these things, I think there's not going to be a huge amount of change. Some practices that are reliant on care plans as the majority of their income are going to feel it, and I think they're just going to have to look at their business model and adapt in a different way. So anyway, thank you so much for joining me on this video. I hope that you found it helpful, and by all means, please pop some comments below or some feedback. I'm always happy to listen and learn. Thank you very much. Bye for now.